So the bigger the radius, the less pressure is needed to overcome the surface tension. To overcome this, our lungs use phospholipid, which makes up surfactant. Phospholipids are hydrophobic, and the more they are compressed, they begin to repulse each other more. The absence of surfactant greatly reduces our lung compliance, causing alveolar atelectasis and tendency towards pulmonary edema. This slide in your lecture notes sums up everything we've just discussed regarding breathing mechanics, as well as compliance, surface tension, and interplay between our volumes and our capacities. The next thing to consider about the respiratory physiology is airflow and resistance. So, flow through the airways is driven by the pressure drop between the airways and the atmosphere. And it's very important that remember, in intubated patients, this includes the endotracheal tube. The extent of the pressure drop, which drives the flow down airways, is dependent on the flow rate as well as the resistance of the airways. Poiseuille's law is the primary director of resistance, where resistance equals 8 times the viscosity, which is also known as the Reynolds number, times length, divided by pi times r to the 4th power. R is inversely proportional to radius to the 4th power, but only doubles, but doubling length or viscosity only doubles resistance. So this tells us that the radius of the airways is one of the most important factors in regards to the resistance to our airflow. Lung volume also affects our airway resistance. As volume is reduced, airway resistance rises rapidly. As lung volumes increase, this is because as lung volumes increase, the middle airways are pulled open, thereby increasing their radius, which we know, based on our equation, is going to be one of the primary determinants of our resistance. So now we get to the primary function of the respiratory structure, which is gas exchange. So gas in the lungs moves across the blood-gas barrier by the principle of diffusion. O2 moves in and C2 moves out. This is governed primarily by Fick's law, and the diffusion is by definition passive. Fick's law says that the transfer rate of a gas across a membrane is going to be determined by number 1, tissue thickness, and number 2, the gas partial pressure. The gas partial pressure, remind us, is the amount of gas in blood is, a principle of the gas partial pressure is that the amount of gas in blood is directly proportional to the partial pressure of the gas. And the solubility constant for the gas in the blood is different gas to gas and dependent on the gas. So gas diffusion across a membrane depends on the concentration on either side of the membrane. We know that our blood gas tissue area in the lungs is enormous, and the thickness is very small. So we have a perfect setup in regards to number 1 for tissue thickness and for slowing of volume to allow for better diffusion. And then our diffusion is going to depend on the factors of our gas partial pressures. You see the importance of the solubility constant with the differences between CO2 and O2. CO2 diffuses about 20 times more rapidly than O2 does because CO2 has a much higher solubility. This process, however, is in general extremely fast in the lungs. And in fact, our alveolar O2 and our the pressure of our partial pressure of O2 in our capillary equilibrates when the RBC is only about 1/3 of the distance of the capillary. The next important thing to understand about this process is the drive for the difference in concentrations of the gas on either side of the membrane. So if we remember, the mitochondria is what's driving our O2 consumption as well as our CO2 production. And we know that O2 delivery is governed by cardiac output and arterial O2. So as long as supply is sufficient, tissues will extract oxygen to meet their needs. Pathology can alter this curve to the point where delivery is dependent on cardiac output due to increased demand or decreased supply. We see a good example of this when we look at the curves of oxygen delivery with exercise. The blood is, in exercise, you increase your cardiac output and the velocity of your blood moving through the lungs, and you see that the time of the blood in the capillary is greatly reduced, causing the equilibration of your PO2 and PO2 to be slightly slower than is normal. So part of this drive for O2 consumption and CO2 excretion, we see that the oxygen goes down a cascade based on concentration. This is also affected by pressure, of course, in terms of the cascade. The pressure factor of the oxygen cascade is governed by Dalton's law of partial gases, which says that your total pressure is your barometric pressure plus your airway pressure, which for us at sea level, we can assume these pressures to be 713, and then you times this by your percentage of oxygen, your FiO2, which is 0.21 or 21%. So the total pressure of oxygen at sea level, accounting for water, elevation, and room air, is about 150 millimeters of mercury. And we see that in the cascade, room air in partial pressure is approximately 159. Our trachea, the concentration is of partial pressure is about 149. Our alveolar gas is approximately 100. Our arterial blood is 92. And then by the time we get down to the mixed venous blood or the capillary beds perfusing the tissues, the partial pressure of oxygen is down to about 40. At rest, this equals a mixed venous saturation of about 75%. So these are two very important numbers to remember when discussing someone's respiratory status, that a normal mixed venous saturation at rest at room air at approximately sea level is 75%, and the partial pressure is 40 millimeters of mercury. The reason why this number isn't completely 100% has to do with how oxygen is carried in the blood, which we will discuss. The vast majority of oxygen is combined with hemoglobin. There is a very small percentage that is dissolved. So when we measure our partial pressures, we essentially negate the dissolved oxygen, as the oxygen that participates most in exchange is that which is bound to hemoglobin.